My name is Konstantinos Diamadoulis. I'm an interventional cardiologist at Ohio State University, and today I'm going to discuss management of the cardiac arrest patient. No disclosures. In the U.S., there are greater than 350,000 annual out-of-hospital cardiac arrests with a survival about 10%. A quarter are due to shockable rhythm, either VT and/or VFib, with a significant portion due to acute myocardial ischemia. 20% will achieve ROSC, while the remaining 80% will remain in refractory cardiac arrest and ultimate death. So in this patient population that's refractory, if these are being driven by acute myocardial ischemia, you can reverse underlying cause by potential vascularization in the cath lab, potential may increase survival. The ultimate goal of CPR and ACLS is to improve survival and long-term outcomes. To reach this goal, you need to provide adequate cardiac and cerebral perfusion, as often anoxic brain injury is the reason these patients do not survive, and need to provide long-term treatment of underlying disease. If ROSC cannot be achieved, this is where potential innovative solutions can be used. This includes ECPR, which is essentially CPR plus ECMO. You need to start with an automated CPR device to bridge the patient from the field to the cath lab. These devices provide effective and efficient compressions, improve cerebral blood flow compared to manual CPR, and also are helpful during transport where giving chest compressions in a moving ambulance may be unsafe for EMS personnel. As mentioned previously, ECPR is CPR plus ECMO. ECMO provides both cardiac and respiratory support. As you can see, a schematic of the ECMO circuit on the right. This is a patient that presented with an ECPR alert. You can see the automated CPR device. While that is functioning, we obtain right femoral venous access and place a 25 French multi-stage venous cannula that goes from femoral vein IVC to right atrium. We then obtain femoral artery access and place either a 15 French or a 17 French cannula. Once those are connected to the ECMO circuit, you can then stop the automated CPR device because the patient is obtaining full support, hemodynamic support. And this is why providing adequate flow is so important. Here are two ECPR patients. The one on the right survived because of a normal brain parenchyma. The one on the left had diffuse cerebral edema with anoxic hypoxic injury due to decrease in hyperperfusion of the brain. There are several ECPR studies that have been published that show encouraging outcomes in refractory out-of-hospital cardiac arrest. Here's just a few for your reference. Data from the French group showed that non-shockable rhythms resulting in refractory out-of-hospital cardiac arrest had no survival. Thus, non-shockable rhythms should be considered a contraindication to ECPR, in which we have excluded from our protocol. Another study that was performed by the group in Sydney showed that survivors had significantly lower pre-ECMO lactate versus non-survivors, and it was the only factor that was shown to be predictive of mortality. This is our ECPR protocol in collaboration with Columbus Division of Fire. You can see field and cath lab criteria to determine if we should place a patient on ECMO. You can review this at a later time in more detail. Let's go over a case. 45-year-old male without a significant past medical history was at work in his office in downtown Columbus and had a witnessed cardiac arrest. CPR was initiated, EMS arrived, it was found to be in VFib, shocked twice, persistent VFib, dual sequential defibrillation for the third shock, which is per Columbus Fire Department's protocol, persistent VFib, thus an automated CPR device was placed and an ECPR alert was called to Ohio State. When the patient arrived at the cath lab, the automated CPR device was in place and he was intubated. Just as the patient arrived, ROSC was achieved and the patient had a systolic blood pressure of 89. Thus, ECMO was deferred at that time. Diagnostic coronary angiogram was performed. You can see there's a stenosis that's significant in the mid to distal left anterior descending artery. And you can see the culprit lesion was a proximal RCA stenosis that underwent successful PCI. Balloon angioplasty was performed. Followed by stent placement. Final image. A right heart catheterization was then performed. You can see low cardiac index of 1.1, cardiac power output of 0.4, elevated wedge. Echo in the cath lab was performed, showing right ventricular and left ventricular systolic dysfunction. Based on the available data and reviewing our cardiogenic shock algorithm and reviewing the case with our shock team, per algorithm, the decision was to place the patient on percutaneous left ventricular assist device with an Impella. Again, you can review this algorithm as well at a later time in more detail. Impella CP was placed. The patient was transferred to the ICU, requiring increase in epinephrine dobutamine infusions. Hemodynamics now demonstrated an increase in R rate pressure, increase in R rate of pulmonary capillary wedge pressure ratio, and a decrease in the PAPI, suggesting right ventricular failure, which goes along with presentation of proximal RCA 100% occlusion. The patient then had recurrent VFib arrest, requiring brief ACLS with achievement of ROSC. At that time, the shock team reconvened, reviewed the data, and the decision was to go back to the cath lab for ECMO placement. It is uncertain whether Impella that increased right ventricular work due to increase in cardiac output precipitated VFib in this patient, particularly in the setting of right ventricular infarct. In addition, the patient underwent PCI of the LAD stenosis. Remaining hospital course on day 2, acute renal failure developed requiring CRRT, though epinephrine was discontinued. However, the patient required continuation of the dobutamine infusion. Patient did improve over the next few days. On hospital day 5, ECMO cannulas were removed. Day 8 was extubated. Day 10, physical therapy was initiated. In day 14, echo demonstrated resolution of left ventricular and right ventricular systolic dysfunction. On day 19, the patient was discharged home with hemodialysis. Here's the echocardiogram just prior to discharge. On third day follow-up, the patient was doing well, was tolerating cardiac rehab, discontinued dialysis due to complete recovery of renal function. In conclusion, ECPR, which is CPR plus ECMO, have shown encouraging outcomes in patients with cardiac arrest, specifically refractory VT VFib. If ROSC is achieved prior to initiating ECMO, very close monitoring is mandatory and mechanical circulatory support should be considered in this gravely ill population. If use of Impella, which increases right ventricular work due to increase in cardiac output, contribute to the development of VFib in this case, cannot be proven or disproven. And finally, the degree or completeness of revascularization should be individualized in this patient population. Thank you.